series has been going on pretty, well. We have covered all the topics. So the soft tissue topics we have covered in great detail. And today we'll be discussing the skeletal surgeries. So since I'm not expert of skeletal surgery, so I have asked two of our friends to join. So let me introduce the subject. So obviously we all know OSA, and we know that in the childhood, the problems start with tonsil and adenoid enlargement, which leads to the palate becoming high arched, right? Which in turns lead to septal deviation, and you can see this air bubble. This we have all discussed in the past. So not only a high arched palate, which is the basic, it also leads to projection of the maxilla outwards, and the mandible going behind, which is retrognathia. So this gradual change in the facial structure keeps on aggravating the sleep apnea issue, and it's a lifelong process which generally starts in the childhood and it goes towards the adulthood. So now we have to understand that we talked about the contents. We talked about reduction of the soft palate, tonsil, adenoid, base tongue, which was all soft tissue. But if the box itself has become small, either by development or because of the continued process of sleep apnea, then there's a limit to which you can reduce the contents. And there's a great role or a big role for the box to be enlarged. And when the box is to be enlarged, that's where the role of our maxillofacial surgeons colleagues, dental colleagues who are maxillofacial surgeons, come into place. Now, what is important to understand that the moment you increase the dimension of the box, the volume of the box, the contents that can be incorporated, increases many a times. It's actually, it goes into square. I mean, if you increase it by the scale factor of 3, this increases 3 to the power 3. That's the kind of volume, because length, square of length, square of breadth, and square of the height. So the volume increases so many more times. And that's what is very, very important, that a little bit of increase in the maxilla size or the mandible size leads to a space which is much, much bigger, which can accommodate large amount of soft tissue. And that's where comes the role of corrective jaw surgery. So if you have the uh, tongue which is normal size, but which is placed behind because of the jaw, then you cannot perform a tongue surgery. You have to bring the jaw forward. So what kind of jaw surgeries are performed? So in the childhood, long time, around 20 years back, we used to, do this maxillum, the distraction osteogenesis. This is again a very, very old. I can show you various advancements which have happened. You can do the distraction in all the directions, and you can actually advance the mandible in all various ways in different forms. So from the time used to do it around 20 years back, a lot of advancements have happened, and you can increase it in all the dimensions. So distraction osteogenesis is a very good tool for the kids, and this is the kind of thing we used to do 20 years back, but obviously uh, this is quite a old thing now. There are a lot of improvements in the subject, right? You do not need these kind of things anymore. And now you can do the imaging. In this case, you can see that the mandible and the maxilla are right in place, and therefore the tongue is not placed behind. Whereas in this case, you can see retrognathia, which is leading to the tongue being placed behind. Now you have two options. If it is a small bit of lymphoid tissue, you can do a soft tissue surgery. But if it is a muscular tongue base, then you would do a patient a much better good by pulling the mandible forward rather than doing internal surgery for obstructive sleep apnea. Similarly, in this case, you can see it is the high tongue base which is pushing on the palate because of retrognathia. So these cases are the best for a maxillomandibular advancement or a mandibular advancement. Mandibular advancement is one in which you pull the mandible forward and create space for the tongue. And maxillomandibular advancement is one in which you rotate the maxilla and the mandible both and bring it forward. So it's a small animation of how it is done. So I'll just move it fast forward. So you take the, periosteum, and then you mark your incisions. Then you use piezo or saw to fracture the maxilla, and then put it into the right position, and then again screw it. A very, very short detail I have tried to explain you. But the final work which is done is amazing. Now you see, look at this patient, how his chin, how his whole jaw was behind, and the whole planning was performed. Obviously, it's by my maxillofacial friends. The pre-surgical planning tells how much airway can be advanced, what is the face going to look like, what are the cuts to be planned, right? And final, result is so nice. So I'll stop my sharing my screen. I'll invite my first friend, Dr. Sukhvinder Bindra from Hyderabad. She's an accomplished maxillofacial surgeon, and she will give you, in the next 15 to 20 minutes, she will give you a good insight into what new technologies, new techniques have come, why maxillofacial surgery, and what new techniques have, to offer to the patient in the last few years. Dr. Bindra, can you please unmute yourself and start sharing your slides?
Good evening, everyone, and thank you, Dr. Vikas, for including me in his program. And I would like to share my screen now.
Just check the schedule and call you back in about 10 15 minutes. We just outside driving. Okay. Can I have your name, please? Okay.
Can you see the slide, sir?
Yes. Can you go into the full presentation mode?
Yeah, I have gone into the full presentation mode. Is it okay now?
Yes.
Okay. Okay. So I'm Dr. Sukhvinder Bindra from Hyderabad. Thank you, Dr. Vikas, going to speak about. So I will start from this slide. As human beings, we are obligate nasal breathers. We are not designed to breathe from the mouth, but due to any obstruction in the nose, which could be adenotonsillar hypertrophy, which could be DNS, which could be turbinate hypertrophy, because of that, the breathing pattern changes. So if you see this in this patient, the mouth breathing, the jaw starts growing downward and backward. And this is, sorry. And this is the result. You can see this is how the nasal breathing patient looks like, or the normal individual looks like, which is ideal airway and jaw placement. And when the jaws, they grow downward and backward, they become narrow and they cause narrow airway also. So this not only affects in the anterior posterior direction, but it also affects the transverse diameter of the upper jaw, which is called as transverse maxillary deficiency. It is quite prevalent in 21% in children, you can see, and 10% in adults. And as ENT surgeons, you are, as Dr. Vikas already explained, that the contents and container box. So we as maxillofacial surgeons deal with the container part or the bony box, which has maxilla and mandible. So protocol advocated that if soft tissue surgery in terms of whatever plasties and turbinectomy and all you do, if they fail, then the maxillomandibular but there has been a paradigm shift over the latest Stanford protocol advocates if there is a complete concentric collapse or lateral pharyngeal wall and the patient has dentofacial deformity, probably maxillomandibular advancement and distraction osteogenesis maxillary expansion can be the first choice of surgery as a skeletal procedure. So who are the candidates who will benefit from this? So
Can you share your slides again, Dr. Bindra?
is
Yes.
it now clear, sir? Okay.
Yes.
So if the patients have transverse deficiency or anterior-posterior. So in transverse deficiency, it is narrow maxilla, high arched palate, narrow mandible. And when you talk about anterior-posterior, it is hypoplastic maxilla, retrognathic mandible, and some patients who have only chin deficiency. So what are the procedures to address these issues? So if there is a narrow maxilla, we can widen it or expand it by using surgical assisted rapid maxillary expansion, which is SARMI, distraction osteogenesis maxillary expansion, DOME, and MARPI, which is mini screw assisted. To address the anterior-posterior dimension, we do maxillomandibular advancement, which Dr. Vikas has shown you. To address the chin part, where only the genioglossus muscle is behind, and the tongue is positioned in the retrognathic jaw. In those cases, we can do the genioplasty or genioglossus advancement. Why relationship of maxilla and nose is very important? So if you see this, 50% of the nose is formed by the maxillary bones. So in case the maxilla is narrow, what will happen? It will reduce the dimension of nasal cavity. It will increase airway resistance because of a narrow nasal passage. It will reduce the lateral dimension of pharyngeal airway. And all these factors contribute to obstructive sleep apnea and make the patient more prone to collapse during sleep. So, and now all of you who are listening to me, just try to see where your tongue is resting in your mouth. The tongue should be resting in the anterior part of palate, right? I'm sure everybody would have tried it. So in case the maxilla is narrow, so then the tongue will not be able to rest here. So where does it go? It will go into the floor of mouth, and which will further block the retrolingual airway. So what do? We widen the maxilla or we advance the maxilla, and we use the principle that roof of the mouth is floor of the nose. So if I widen the roof of mouth, it will indirectly widen the floor of nose also, and that's how we gain the volume in the nasal cavity. I'm just showing you this video which shows surgically assisted rapid maxillary expansion. This expansion device we have anchored on the teeth, and these are the Lifford 1 osteotomy cuts which we make. There is a mid buccal cut. Mid palatal cut is not always necessary. Then the key given for the screw expansion, when you activate it, the two maxillae, they start drifting apart. And when adequate expansion is achieved, after that there is consolidation period. And then we start aligning the teeth, because ultimately patient has to eat also. So this is how pre and post surgical expansion cases look like. This is the same procedure, but here there is a change in the device. That device which I showed you in the video was anchoring on the teeth. That was a tooth-borne device which is used in SARMI. And this is distraction osteogenesis maxillary expansion, where we use anchorage from the bone. So this is distraction osteogenesis maxillary expansion, where anchorage from bone is gained. The cuts are same. Bilateral Lifford 1 osteotomy. As ENT surgeons, you are familiar with Lifford 1 fracture. So it is the same Lifford 1 line. The fracture is there, but we are creating osteotomy. And this is a mid-palatine. Here we are taking anchorage from bone. So this is a bone-borne device. And we are using hybrid, where we are taking support from bone as well as from the teeth. And there is substantial data out in literature to support that maxillary skeletal expansion techniques increase the airway volume, improve breathing, and various authors have published that 9.7 to 12.9% increase in the volume is gained. So when you expand the maxilla, not only the volume increases, you have seen the high arched palate, which you can appreciate here. So when we expand it, the palate also becomes shallow. So when palate becomes shallow, the tongue starts resting in the proper position where it is supposed to be. And that helps in opening the airway at the retrolingual area. Now, all of you imagine wearing a narrow shoe. So if you want to slide your foot forward, you will not be able to. But if we widen the shoe a bit, you will be able to slide your foot forward. So here the shoe is upper jaw and the foot is lower jaw. So when you widen the upper jaw, the lower jaw also comes forward. Even if there is increase in 3 millimeter forward movement, as Dr. Vikas told, so imagine the volume increase 3 into 3 into 9 cubic millimeter. So that helps in decreasing the AHI and other indices which are related to the sleep parameters. And SARMI and DOME both are equally effective. And now we should know who are the candidates who will benefit from this. So any patient with narrow maxilla. So I will request my ENT surgeons, when the patient comes to you, you ask the patient to open the mouth to check their tongue position and tonsils, right? So now look upward towards the palate and check how it is. If it is narrow, high arched, then if there is any maxillary hypoplasia, sometimes the patient will come to you with CPAP non-compliance because of the retrognathic jaws. The CPAP mask is not fitting properly, and when on dice, and you see that there is improvement in the saturation when you advance the mandible. And in pediatric patients who are syndromic, in those cases we need surgical expansion. Otherwise, in pediatric population, non-surgical is beneficial. So what are the types of expansion we are doing? So first is microosteoperforation assisted RME, distraction osteogenesis maxillary expansion, surgically assisted, and MARPI. Now I will take you through few cases who have been operated by us in tandem with ENT surgeons for a holistic multi-level surgical treatment. Multi-level surgeries when you address the all the levels from nose to the hypopharynx. So in this patient of 43-year-old female who came with obstructive sleep apnea and snoring, so we have done, she has undergone septoplasty, turbinoplasty and barb pharyngoplasty along with dome procedure on the same day under same general anesthesia. And this is how she is after 1.5 years, where we have gained adequate width of the upper jaw. And when we took her post-op sleep study, her AHI index had dramatically reduced from 32 to 3. And happened, the best advantage of distraction osteogenesis maxillary expansion or dome is you get a near parallel expansion from ANS to PNS. And this is just a CBCT scan to show the increase in the volume of airway. Another case who was treated as a part of multi-level surgery, where this kid had, a 17-year-old girl had undergone adenotonsillectomy and SARMI in the same general anesthesia. So this is how she came. So 1 day post-op, 3 weeks and 6 months, 9 months. And this is how she is after 4 years of post-operative, and the symptoms have subsided. A 32-year-old male patient who have been, and you can see a significant after 2.5 years, not only in the jaw, but in the symptoms also. SARMI was done in a treated cleft palate patient also, where you can see when he came pre-operatively, you couldn't see any maxillary tooth. So it was not only the width, but the anterior-posterior deficiency was also there. So when we widened and we protracted a little bit, and then this is the final result, where you can see good enlargement of the jaw, and you can see all the anterior teeth. The another procedure which addresses the anterior-posterior dimension is maxillomandibular advancement. We give the Lifford 1 osteotomy cuts. We advance the mandible by bilateral sagittal split osteotomy, and we advance the chin by genioglossus advancement or genioplasty. So in this video, I'll just show you how mandibular advancement helps. So this is a constricted airway, and this is how the ideal airway. So pre-surgical orthodontics is not mandatory. Sometimes we do the surgery first approach because the patient comes with sleep apnea. So this is the Lifford 1 osteotomy cuts, and this is the bilateral sagittal split osteotomy cut. We advance it. fix it to the new desired position where it is supposed to be. And this is how the improvement of airway after doing maxillomandibular advancement. So the candidates who will benefit from MMA are the patients who have moderate to severe OSA with dentofacial deformity where there is retrognathic mandible, hypoplastic maxilla, and in case of the patient who have undergone soft tissue surgery but inadequate improvement was seen, and patients who have inclination that yes, they want single stage surgery to address all the issues. So pre-surgical workup includes comprehensive systemic assessment, dental and teniofacial assessment, imaging, photographs, models, consent, lateral cephalogram, and CBCT help us in deciding the treatment plan. And photographs are needed for the patient to see how they were looking pre-operative and how you can compare them. So we take the CT scans, we send it for the virtual. In virtual surgical planning, we advance the maxilla and mandible. We can take them forward, the aesthetics of the patient and how we can rotate the maxilla. So the procedures are Lifford 1 osteotomy with advancement, BSSO with advancement, and genioplasty. So these are the few patients who have been benefited by maxillomandibular advancement procedures. How does it help? It advances both maxilla and mandible by around 8 to 10 millimeter, and this helps in increasing the airway the 3 dimensions. It enlarges velopharyngeal space. It enhances. It reduces the collapse and obstruction of pharynx. And when you advance the mandible, what happens? The genioglossus muscle, along with other suprahyoid muscles, they come in the new position, which keep the tongue upward, forward, and away from pharynx to reduce the symptoms of OSA. And this MMA procedure is an effective tool and has a place in management of obstructive sleep apnea. And why was it chosen for OSA treatment? Because of high success rate. It's a good alternate for CPAP intolerance in indicated case. It improves the quality of life, and the best part of MMA is it improves multiple structures and gives a patient long-term permanent solution. Advancement genioplasty, where we see the tongue is at fault or the base, so we perform it. This is a beautiful procedure. You can do it as a part of multi-level surgery. You can nose and palate, or you can combine, you can use it as a multi-stage surgery that you can address the soft tissue first and then you can do the genioplasty in retrogenia and retrognathic cases.
Surgeons can perform a sliding genioplasty.
This is how the genioplasty is performed, and this is the new position where we fix it.
Minutes with chin projector elevation.
And this is how we check it in the OT. And this is how you can appreciate this. In this patient, it was done as a part of multi-level surgery. His nose, palate, and chin, they were all addressed in the same sitting. So in the end, I would like to conclude by saying it, OSA is a structural disorder which involves both soft tissue and skeletal component. So debate is not whether bony box or the soft tissue, but we should always plan a structured scientific protocol to decide which should be done first. It is not opposed like bony box or soft tissue. No, it should be whether we should be addressing the soft tissue first or the bony box, or we can do it together because soft tissues open the airway, bone keeps it open, and collaboration keeps it stable. So when OSA surgery works best not by cutting more but by rebuilding better. When ENT and maxillofacial surgeons unite, function aligns with structure, and patients finally breathe better. Thank you so much for your patient listening. And if there is any, please ask.
Thank you very much, Sukhvinder. Sriharsha, is there any questions? People have asked any questions to Sukhvinder. She's traveling. So we'll ask her questions first. And meanwhile, you can make Nehal the panelist so that he's ready to share his screen.
Yes, sir. I've made him the co-host. So there was one question from the audience. So what is the objective criteria to call a palate as high arched palate?
When you see objective criteria, see, we are not treating only the scan. Okay. So first is when you evaluate the patient. So I cannot give you a certain measurement, accurate measurement, because there has been different measurements by the different authors, population wise, race wise, because Indians have different palate, Caucasians have different, Americans have different. So objective assessment as of now is not available with me to tell you ki this particular will call you as a high arch palate. But when you check in the patient and on the and on the CT scan, so we can check around on the when you take the model, on that we do the measurements and then we analyze it. So I
So,
cannot give measurement as such. I'll definitely find out and give you if I have it in the literature for Indian population.
so by and large, if you see a air shadow between the palate
Yeah,
and the tongue,
and
which is
tongue,
really significant, you call it a high arch palate.
high arch palate.
Perfect. So thank you very much, Sukhinder. You are traveling, but I believe that you would do justice to the subject, so I called you. Thank you for joining at the last moment. I
Thank
know
you, sir.
it's Sunday evening and you are traveling. Thank you for being here.
Thank you, sir. Thank you so much.
Thank you.
Sir, there were few more questions we'll take up at the end of the presentation.
Yes, I think Nehal is with us.
Hmm.
Let Sukhinder travel now.
You can
It's
just
a
post me the questions. I will draft the answer and
all
send
right.
you.
So
Yeah.
you can mute yourself.
Hello.
You can mute yourself and look at it. And
Hi,
just
Dr. Sukhinder.
yeah.
Hello. Yeah.
So Dr.
Dr.
Nehal,
Vikas.
yes, who is that?
Yeah.
Hi Nehal.
Yeah, I'm Nehal.
Yes,
Nehal.
yes, hi Nehal.
Yeah.
So Dr. Nehal Patel is one of the best maxillofacial surgeons I have come across, and he performs maxillomandibular advancement surgery at my place, and his skills are just awesome. Patient is out of the hospital in flat 3 days. So hardly any swelling, very clean hands. So I would invite you, Nehal, to talk on skeletal surgeries for OSA to this August gathering.
Thank you, Dr. Vikas, for inviting me. I missed so many actually sleep meets. So I'll just go to the main topic. So the main objective for this lecture is understanding the role of MMA in OSA management, review of principle in VSP, because see, now we have moved forward from conventional way to doing surgery planning for VSP and discussing more of indication, workflow and advantages, and few of the cases what we have done together, me and Dr. Vikas. So when MMA surgery is required, so I am absolutely dependent on the analysis of otolaryngologists when they say, okay, this is the case where mandibular retropalatal or retroglossal, there is a airway problem and there is a retrognathic mandible, which required actually the MMA advancement, and that is where my role comes in a play. So I usually depend on analysis by Dr. Vikas, where he says, okay, this is I have done a dice and this is the reason we need to do, and we go ahead with the MMA. The main indication is multi-level airway collapse confirmed by DICE. So DICE is one of the most important thing which I need to understand which level is actually the obstruction is. So what we can do as a maxillomandibular advancement. So as a maxillomandibular advancement, you can expand the retropalatal as well as retroglossal airway. And when we do it in indicated cases, the success rate is as high as 95%. So how we do it, I'll be just going through it. But before I go there, what I would like to explain is, when I receive a patient of obstructive sleep apnea who is indicated for maxillomandibular advancement, what I evaluate is one is function, one is age, and one is occlusion, because when we change that, it matters a lot, because when you advance the maxilla and mandible, it changes their aesthetic. I mean, it changes their face, and that matters a lot to the patient. So we need to understand where exactly and how we need to do it. So I'll just give you a few of the example. Like if the patient has a obstructive sleep apnea with the normal occlusion, like you see here, there are two photos. One is absolutely normal. One there is a, I mean, there is a little bit of misalignment. Majority of the time patient comes for functional correction, like correction of the obstructive sleep apnea. So if I tell them that you need to correct your occlusion also, they may not be get ready, because the main issue here is a function. And this is where when I take a lecture in a maxillofacial society, I need to make them understand that occlusion does not matter. You have to change the airway in a way that they maintain the occlusion. So that is why the VSP, the virtual surgical planning, comes in a play, where we can plan airway changes in a way so that they can maintain their chewing function, as well as they can improvise in their airway function. This is one of the example. This is one of our patients where we do analyze patient CT scan, and we do couple of things like cephalometric analysis. And if you can see on the left side, there is a airway which is constricted. And how do we plan it? Is it depends on patient's aesthetic. See, you cannot advance maxilla and mandible just because you have to expand the airway. You have to consider their age, their aesthetic. So this is how we plan. It depends on their lot of factors. One of the most, so we analyze the airway through virtual surgical planning. So this is a constricted airway here, and if you can see here, the volume of the, when I analyze, I just analyze the DICOM file, and if you see here, the volume is of this patient is too low. It's like 2.5. So the volume in the sense of it's a three-dimensional area. It's not like a linear thing. It's like anteroposterior, medial, distal, and the volume is only 2.5. The normal volume should be for the airway is 15 to 20. So usually the MMA, when it comes in the conventional way, it defines an advancement of the maxilla and mandible. That is a two-dimensional theory. Where it is not correct is when you think about two-dimensional, it is you are advancing a maxilla and mandible, but you do not have a predictability of volume changes, and there the virtual surgery planning plays a major role. So when we actually analyze the patient, we analyze for incisal sow, we analyze for corneal widening, we analyze for maxillary cant, buccal corridor, occlusion, and comorbidity. And these are the factors which plays a major role. When I decide, or when Dr. Vikas says, okay, you have to do MMA, these are the factors which plays a major role. If the patient is younger, the results, they are more favorable. It does not mean that you cannot do a patient who are more than 50. You can do. The only thing is you have to consider the comorbidity, like hypertension, or there is a chances of high occlusal plane and the cardiac condition. Now, if you look at these four patients, this guy is 23 years. He was referred for a OSA. But if you look at his smile, he has a gummy smile. So I have advantage in doing MMA because I know it's a gummy smile. So I can impact the maxilla and bring the maxilla mandible forward. In this 3 patient, this guy is 49, he is around 39, he is around 35. The problem in these 3 is they have a normal smile, or in this he has a little bit of gummy smile. All these 4 patients are actually diagnosed obstructive sleep apnea patient and referred basically for MMA advancement. The problem in these 3, if you do advancement, you are compromising the aesthetic. So how do you deal with them? If you look at them, there are 4 different profile. One, so what I analyze is, one is nasolabial angle, one is thyromental distance, one smile at rest, and one smile at full smile. I mean, the ginger also at the full smile, because it gives an idea how much you can advance. Now, majority of the time when obstructive sleep apnea patient get referred, there was some occlusion like this. There's a class 1 occlusion, some malocclusion. But when I tell them that, okay, you have to get the orthodontic treatment, they may not be ready because that's not their primary concern. The primary concern for them is basically the obstructive sleep apnea. So how do you correct that? So there is a method to do that. It's called counterclockwise rotation. Now we will just take a case one where if you see this guy, he was referred, his AHI was around 30, and when he was referred, so we analyze his smile at the rest on the lateral profile and smile, I mean the gingival so at full smile. So if you see here, there is a good gingival so. So when I see something like this, I know I can advance this mandible more because I have an ability to push the maxilla down. Now that's his CT scan. So best thing to analyze these patients are on the CT scan. Now, so what I analyze is usually it's a occlusal plane angle or the mandibular plane, and so this is the angulation and the airway. So there is a constricted airway here where patient needs maxillomandibular advancement. So what we do is we plan this on a virtual surgical planning. So we take the impression, we analyze this patient, and that's the airway volume from the beginning. If you look on the left side, the airway volume of this patient is only 5 pi cc. That's too low. So area volume for me, so we start from, so it's a 3-dimensional measurement. It's not just anteroposterior measurement, it's a 3-dimensional measurement. The volume, normal airway volume for a normal individual is around 15 to 20 cc. So this is the entire process, how I plan this patient. When you need to keep the same occlusion, you have to understand that they don't require orthodontic treatment. So you remove everything. You start planning with your maxilla. You correct in the AP position. And you counterclockwise rotate. So if you look at this maxilla, it is going up. And on the left side, I am just, so if you see that movement, the point of rotation right now is the center of the palate, and it is rotating down from the posterior side, and anteriorly it is going up. Now this movement does not change the aesthetic of the middle face, but at the same time it increase or it allows the mandible to come forward. So if you look at here on the left side, vertically the maxilla has gone around 4 millimeter, we have advanced the maxilla around 6 millimeter, but if you see it, this pyriform rim, it remains in the same position. So now, in that particular move, when you give that movement, it allows the mandible to come forward without changing in the occlusion. Without changing in the occlusion. And that is where you can advance your maxilla, mandible, and that increase your retroglossal airway. That's so the mandible has come forward at pogonial level, I mean at the chin level, around 12 millimeter. And further you can do a genioplasty, which can increase it can pull basically your muscle, suprahyoid muscle and the tongue muscle. So the ultimate increase in the volume, I mean the length is around 16.5 millimeter. So this is what we had done. So at chin level, the advancement has happened around 16 millimeter without even compromising. So this is how we do it. This is how you cut the maxilla on the other side. And when you do a counterclockwise rotation, so this is where you can advance your mandible, sorry. This is where you can advance the mandible. And that's where, from where we started, and that's where we are. So same occlusion we started. You can see here on the left, I mean, one side, we have just impacted the maxilla, but at the same time, we have gained that mandibular advancement. So what it does is, it increases the gonian angle, and that's what we have planned. So that's the impaction of the maxilla, and that's the advancement. So this is what we have planned, 16 millimeter, that is 1.5 centimeter. And that's actually the actual post-op CT scan of superimposition. So you can see there, exactly what we planned, it was executed. And that's actually a post-op airway. Okay, so this is actually a superimposition of pre-op and post-op. So the orange line is a pre-op airway, and the green is basically a post-op airway. So you can see the increase in the AP position, and that's the medial distal. So you can see the entire three-dimensional volume of the airway has been increased just by doing a counterclockwise rotation. This is another case. Now, if you look at this guy, when he was referred, he has a AHI of almost 35, but aesthetically, he's fine. I mean, there is no problem in that. But you need to, so when I need to increase the airway by increasing doing MMA, what I see is this area. Now, if you look at this, there is a sagging. There is a sag of the suprahyoid muscle. There is a little bit of gummy smile. Now, this gives us an advantage of doing a planning. So, again, it's the same thing, counterclockwise rotation, advancement, and this is what has been done. At chin level, after genioplasty, it was advanced for around 18.7 millimeter, and this is what he is after. So he looks actually more younger than before. So I call this procedure as a reverse facelift, because in the more the patient who are more than 40 years above, when you do this procedure, it actually stretches the lip skin, and it looks, they look more younger, along with the treatment of obstructive sleep apnea. And this is, so this is like an impaction where maxilla is impacted for around 3 millimeter, and counterclockwise rotation where posteriorly it has come down, and that's where we get advancement of the mandible. So this is what the occlusion we started. This is the after. It has not changed. Uh, it has changed a little bit, but it settles down over a period of time. Now this is very typical. When patient has obstructive sleep apnea because of the anatomical problem, like retrographic mandible, they tend to keep their face ahead to open up the airway. So if you look at this neck, there he is keeping it ahead. The same thing. Now, if I ask them to get the treatment for this teeth, they may not be ready, because the main issue is the obstructive sleep apnea. So you have to consider doing in the same. So this is how I do it. So when I see this patient like this, we analyze how much we can advance, what will be the impact of counterclockwise rotation on the airway, and what will be impact on their aesthetic. So this is the actual measurement where we have advanced it for more than 14 millimeter, and then we simulate how much will be the aesthetic change. If it is in a range of reasonable changes, so that's the pre-surgical, that's a post-surgical. So it is so measured that usually now Dr. Vikas said it's third day, I prefer to discharge in 24 hours. I mean, it's not that complicated anymore. So this is, so now you look at the position of the neck here. Once they have that airway changes, and when they start breathing properly, their posture also change. And this is what their occlusion looks like. So thank you.
What an amazing presentation. Thank you, Nehal. It's like a sci-fi movie for all the ENT surgeons. Your virtual surgical planning, and I'm sure artificial intelligence. You can stop sharing your screen.
Yeah, okay. Thank you.
And no, so that's what I said. It's a very, very highly skilled work, and a lot of softwares are involved. And therefore, the whole work has become quite sophisticated. And therefore, the number of base tongue surgeries that I was doing earlier have reduced, because if the problem is with the muscular tongue base, I offer them maxillomandibular advancement surgery first. But obviously, people have to get aware, and they have to accept it. In times to come, they will definitely accept it better. So, Harsha, are there any questions for Nehal?
Yeah, there were, ma'am has already answered them individually, but
Yeah.
we can read out the questions and discuss.
Yes, Nehal, why don't you just start your camera so that we can see you, and Harsha will ask you the questions which have come in the chat box.
Hello. Yeah. So one of the question was what is the objective criteria to call a patient as high arched palate?
Yeah.
Uh,
If she, yeah, go
I have
ahead.
already,
yeah,
I
I
have
think Dr.
already
Sukhvinder is
texted
already
it. Yeah,
answered
I have
that.
already texted it so that everybody can go through it. This is the journal guideline, because every population has different index. In India, still we are yet to get the statistics, okay, ki this much will be the highest palate. There is no objective, okay, 5.7 or 6.7. It's not like that. But usually more than 15 millimeter depth in adolescents or adult is considered highest palate.
All right.
So next question is, what is the good time for palatal expansion with
Yeah,
braces?
palatal expansion. I will answer this question. I'll take little time. Is it okay?
Yes, yes, go ahead.
Yeah. So, I will talk it for the age point of view. I'm talking about non-syndromic cases here. So, first is from the age group 5 to 12 years, we just need to do non-surgical expansion. We don't need to do any surgery. You can do MARPI, which is mini screw assisted, and we can do simple rapid maxillary expansion, RME. When it comes to 12 to 16 years of age, in that age group, because the mid-palatine suture and zygomatico-maxillary sutures, they start fusing. So in female patients, 12 to 16 years, we can do RME with micro perforation. And second option, MARPI, where you don't need to give any cut. But in case of male patients, where the sutures have fused, in those cases, we can do dome procedure, distraction osteogenesis, maxillary expansion, which will be good. Okay, and then comes the age group which is above 16 years. So 16 to 30 years of age group in female patients, dome and sarme, they both are good. And male patients who are above 30 years or 40 years with thick zygoma, Indian population have very thick zygomatico maxillary sutures. In those cases, sarme will be the best option. Is that clear? And somebody asked me, hello?
Yeah, go ahead. Very nicely
And
explained,
somebody
very
asked
clearly
me,
explained, but
yeah,
yes,
and somebody asked me about the braces part. See, braces are to align the teeth. So we shouldn't be doing braces or alignment before 12 years of age because most of the permanent teeth have not erupted in the mouth. So alignment starts when you are getting all the permanent teeth have come, which comes around 12 and a half to 13 years of age group. Then you should do the expansion and the alignment.
very clear.
Yeah.
Very clear.
And somebody asked about the complications. See,
Yeah.
there are intraoperative complications and postoperative complications for any procedure. I will not call infection, bleedings, infection, edema, swelling as a complication. It is a sequelae of surgery. But during bilateral sagittal split osteotomy, specifically in the mandibular advancement, we are splitting the mandible. That time there can be injury to the inferior alveolar nerve, and then if your instruments are not in a proper not placed in a proper way, you can cause an inadvertent fracture of the cortical plates. Okay, and then while fixing, as Dr. Nehal had described, condylar sag, the condyles and TMJ should be in the proper position when you are fixing the mandible, because otherwise when you will release the intermaxillary fixation after surgery, then the occlusion will change and condylar sag will happen. Post-operative infection, which is minimized nowadays because we use all the sterile technique. Paresthesia of inferior alveolar nerve, paresthesia of lingual nerve, they are the most common post-operative sequelae or complication, along with some disturbances in the occlusion, which we can take care after giving the post-op orthodontics. Minor correction can be done with post-operative orthodontics.
So that has also reduced by using piezoelectric. Is that
Yes,
correct?
sir. That has been used. In nerve injury has been taken care, and occlusion, if we are doing surgery first approach, because patient came with apnea, we cannot waste time on pre-surgical orthodontics. So in those cases, we tell the patient that post-surgery your occlusion might have some changes, so that we can address with the post-op orthodontics. And sometimes if we have time, we are doing a multi-stage procedure. In those cases, we can go surgery and pre-surgical orthodontics. We can do that.
Very nice. Very nicely explained. Harsha, are there more questions?
Yes, sir.
For
Yes, sir.
yeah.
So, um, one question is, if we do any this facial surgeries, do they
Yes.
alter the biometrics in identities like Aadhaar card?
Yeah, I think Nehal, can you answer
Yes,
this question?
yes. I think Nehal will
Yes.
agree to me. Most of our patients,
Yes.
they have to go for it.
So
So
We are
let
doing
yeah,
all
I
to go
mean,
from
it
simple
is sometimes so
profile.
drastic that they have to change it. As I
Yes,
said, see, this is more of a, it happens like a more of a reverse facelift,
yes,
because when you do a surgery for OSA, they are in their mid 40s or 50s. So when you advance it, you are basically stretching the skin. So when you do a facelift, you are pulling it the skin, it happening from the inside. I mean, we are advancing the skeletal, and that's why the skin is becoming more and more tight. So yeah, of course, I mean it changed, and sometimes it changed so much that one of my patients said, "Doc, my iPhone does not recognize my face now."
I completely agree to Dr. Nehal. Yes, it changes the biometrics and the patients have to
And it's for the
change that.
good. It looks better
That's
most
what,
of the time.
obviously. Sir, we are treating a problem and aesthetics is a bonus.
Yeah.
So,
So
so
as
now
I mean, it's like a aesthetic a byproduct of functional improvement.
Yes.
so
Yeah.
if my face is normal,
Yes.
then if you change the aesthetics of the face,
So how do you define normal?
that's what I'm saying. No, suppose if all the angles are correct, I do not have a
No.
retrognath.
So why people go for a facelift after 50,
So you are
55?
you are saying that when you do this, it will only look better. It will not look worse.
Exactly.
In any
Exactly.
case,
Yeah.
that's what
In
I want.
any case, the plan is such. In plan is such that the aesthetic is a byproduct. Main main
Is
challenge is
the
the functional improvement. But when the aesthetic improves, it is in the better way rather than in the worst way, basically.
Can I just add something to it?
yes, please.
Yeah, if your question comes this way, Dr. Vikas, that if the patient has already a bimaxillary protrusive kind of case and
Correct.
has sleep apnea, in those cases, what we do, we can do the segmental osteotomies also. Okay, so along with the Leaford 1 advancement, so
Yeah.
we can do the premolar extraction, push the segment back and advance the whole thing. In those cases, that can be addressed in a, you can say, two-piece maxilla or three-piece maxillary surgeries, which take care of the aesthetics as well as the function which you are asking.
Very nice.
Yes.
Harsha, you have more questions?
Yes, sir. Yes, sir.
Go ahead.
So yeah, next question. Can you briefly tell us about this mandibular advancement devices?
Device.
Mandibular advancement devices are there in the market. I will never suggest anybody to go for an over-the-counter mandibular advancement device because there is no evidence for its efficacy.
Yes.
So this has
Good.
to be customized for the patient, titrated for the patient. Nowadays, we are working with ENT surgeons where when we do dice, at that time we are putting there are 2 3 devices you can use, um, impression material also, when you can where you can advance the mandible and see whether it is actually benefiting the patient or not. And these devices, you can take the measurement, you can take the digital scan and get them fabricated, and they are titrated that at this particular 3 millimeter or 4 millimeter advancement, how the patients are improving. You can even do dice, and you can even use these devices on CPAP patients who are on CPAP, so they can also use it. But don't go for over the counter, get it customized and get it fabricated from the person who knows how to make a mandibular advancement device, because there are few complications associated with it. You try to keep your jaw forward overnight every day and see how what happens after 2 months or 3 months. You will have TMJ, some amount of muscle soreness will be there. So these kind of a little bit complications are there with the mandibular advancement devices. So this is my take on MADs.
Perfect.
And it should always be titrated.
Yeah.
Yeah.
I think one of the questions I can see is during the surgery, should the intubation be nasal?
It's always nasal.
It is always
It's
nasal, sir. There is no way it can be oral
It's
intubation.
always nasal.
Always
perfect.
nasal.
So then another question I can see is what should be the plan in complex cases having deviated septum, soft tissue in pharynx, and also big bass time? So this question I'll take.
Yes.
So see, there's no competition between a soft tissue surgery and a skeletal surgery. It's always complementary. You can understand that most of the time the soft tissue surgery is a easier uh, thing for the patient because the healing time is not more than 2 weeks. Now with the piezo, even the skeletal surgery is becoming better. So when I started around 20 years back, piezo was almost not there, and that time they were only using saws. So obviously the nerve trauma was more, the overall swelling was more, the soft tissues used to get, inflamed. So in those times, the skeletal surgery was a little bit of a bigger surgery. But honestly now, even if I do not do it, I know that my friends will do such a good job, and the patient will not be in, even as much pain as a soft tissue surgery. So for the correct patient, I believe if somebody has a big base tongue, which is muscular, and he has a retrognathia, I will straight away advise him a maxillomandibular advancement because I know that he'll get a better result. On the other hand, if somebody has a lymphoid base tongue, I'll possibly do a soft tissue surgery, the base tongue reduction. So if somebody has a deviated septum and you advance his mandible, nothing will happen. You still have to open up his nose. So this question has to be taken in a way that whatever is the most prominent problem has to be dealt in that manner. And skeletal surgeries are very good nowadays, and it can complement, as Sukhvinder showed, that many of the things had been done at the same time. The patient was operated for his nose, palate, and also, some kind of a skeletal surgery at the same time. Even that is possible. So we have to complement, and this whole field will progress only when both the surgeons will actually complement each other.
So I would like to answer this question.
Yes, Nehal.
What is the time the patient should be on MMF? 0 day. We don't keep patient on the maxillomandibular IMF, because now we use a rigid fixation. They don't need to be on a maxillomandibular fixation. They can start their normal diet once the normal anesthesia period is over, that is around 6 hours. So initial few days they has to be on a liquid diet, but there is no MMF. We don't close their mouth. Maximum what we do is we put a elastics. So elastics are like a crutches. So when you do something on your bone in your leg, you need to reduce the load which you are giving on your leg. So you use a stick. The same way we just give a elastic sometime, but there is no need of MMF. It's absolutely not required. MMF is so you don't need to close the mouth of the patient for 4 to 6 weeks. Not at all. So will this advancement will start TMJ issues? So majority of the patient who requires MMA for OSA already have a TMJ issues. Because why the mandible is retrographic is because the developmentally the TMJ has an issue. So it's an adaptive capability of the TMJ. Majority of them, they do not require it. If they require it, it is sometimes symptomatic, which you can treat it just with the simple physiotherapy or medicine. Sometimes in 1% of the cases, they may get some issue which can be solved simple with the arthroscopy. That's it. Otherwise, TMJ is not at all issue for MMA in OSA. I mean, so you don't put patient on MMF. You don't put patient on a long-term. It is everything is planned. So even the fixation is so rigid that we don't change much of the dynamics of the TMJ. So they don't develop issue. If they develop, it may be a temporary. It's not long-term. But if you look at the risk-benefit ratio of correcting OSA and developing TMJ issue, I think the benefit is more. TMJ issues are very short-lived. I mean, they get resolved
I'll
very
explain
fast.
in a very simple way that with mandibular advancement devices, you tend to pull the whole mandible along with the, TM joint forward. Therefore, you develop TMJ.
Yeah.
Here, you are actually, splitting the mandible and pulling only the front part forward.
So we are not changing the TMJ dynamics basically.
Therefore, there is no TMJ issue with the maxillomandibular advancement surgery, but the TMJ issue is with the MAD, the mandibular advancement devices.
Yeah.
Yes.
So I just put it in a simple way because
Yeah,
maybe
it
surgeons
is
are
much
not used
simpler
to.
way.
Yeah, because you are
When we
used
are
to this.
overstretching a muscle, it will create problem. But when we have already split it and then advance it, it shouldn't be.
Absolutely.
Sometimes a little bit of tenderness and soreness that can be taken care by
That is
physiotherapy and post-op analgesics and
absolutely.
muscle relaxants. Yeah.
She's on a call since last.
So I think a great discussion. Very nice. Any more questions, Harsha?
Yeah, she's on a call. मतलब वो उसका कुछ conference call था, on call था.
Do you have any more questions?
Presentation, so she's on a call. That's why she cut Sheetal's call, I think.
So I think we have almost covered all the issues.
Okay.
If anything else, passing the final, Sukhvinder, any message from your side for ENT surgeons?
Yeah.
And then
My message
after
for
you, Nehal.
ENT, my message for ENT surgeon first is when you see the patient, okay, when you are looking at the patient, just see the patient from the side as well, not only from the front. See whether the maxilla or mandible are retrognathic or hypoplastic. Second, when you ask the patient to open the mouth, look at the palate. If it is high arch, narrow palate, is there any crowding? Check the bite. I have given few ENT surgeons different bites of the patient, which may indicate that the patient has some skeletal issue. So I can share that also. I have that in a document, so I will share it. Dr. Vikas, he can circulate among you.
Sure.
And that you have to look for and position of the tongue. I mean, you people always check FTP, right?
Correct.
So FTP and Malam, as dentist and maxillofacial, we are more towards Malampati score. So it is almost the same, but you as an ENT surgeon, please look towards the palate also. As Dr. Nehal had shown you different faces, buccal corridors. If there is darkness in the buccal corridor, there is crowding of the teeth, there is narrow high arched palate. So all these cases should be evaluated together with your dental fraternity.
And any message from you, Nehal?
No, I think Madam has already summarized.
Already summarized.
Only one message is MMA is not as scary as it believed to be.
Absolutely. That's what I have already said, that when I started around 17, 18 years back, MMA was a no. But
It
now
is.
I'm a great supporter of MMA.
It is not as scary.
Absolutely.
It
And
is.
it is a yes now.
Yeah. Yeah.
So I thank you both of you for joining us and enlightening our ENT friends,
Thank
because
you.
you are experts in this field and we require your fraternity. And in the forthcoming ISSS conference that we have in Mumbai in February 20th to 22nd,
Yes,
we'll
yes.
have dedicated sessions on dental. We'll deal on all these topics as well.
Sure.
So on 21st and 22nd, there will 2 days, there will be dental, a room dedicated to dental, where we'll deal with MAD, MMA, and all kind of surgical procedures on the skeleton. So I thank you very much. I hand it over to Harsha.
Thank you, Dr.
So
Vikas. Thank you, Dr. Nehal. And thank you, Dr.
Thank
Harsha.
you, ma'am. I think
And
we
thank
missed a
you.
lot of time each other.
Thank you, but now we met finally.
Yes.
And thank you, lovely audience who sat through the session, and it was a good interaction, everybody. Thank you
Thank
so
you.
very much.
Yeah. Thank you, Dr. Vikas.
Thank you.
Thank you, Dr. Sukhvinder and Dr. Nehal Patel, sir. With this, we complete the core OSA topics. Over the last 10 webinars, we have covered all the core topics. And we have two more topics in this series. One will be assessment of the results of OSA and how do we deal with our failures. And it's a very interesting topic. And we'll be meeting again on 21st December, followed by last topic on the series, which is about the CPAP. So of course, the dates have not been finalized, and I will be having a discussion with sir, and I'll be posting it in the group. I thank Dr. Vikas sir for giving his valuable time, and for both the guest speakers who have joined us and enlightened about the skeletal surgeries. And that's all for the night. Thank you.
Thank you. Bye-bye.
Sorry if
Good
my
night.
signal was missing and I was
No,
not
it
here,
was
but
it was
I was
perfect.
because
It
I
was
was
perfect.
in a driving. We are driving back to Hyderabad, so
Perfectly all right. Thank you for joining.
thank you.
Thank you.
Thank you so
Bye.
much, Dr. Vikas.
Thank you.
Thank you.
Thank you. Thank you.